Hey everybody, we're going to start in a few minutes. We're just going to let everybody join and then we'll kick things off. So glad you're here today. We will get started approximately 2 to 3 minutes from now. Thanks again for joining. This is my favorite part, is watching all the participants join the Zoom meeting. We appreciate y'all being here. We will get started momentarily. All right, so let's kick things off. Good afternoon, everyone, and welcome to our session today. It is so wonderful to see so many of you joining us for this important conversation. I'd really like to begin today's session by celebrating. We have a lot to celebrate today. It really is a tremendous achievement for the field of cardiopulmonary rehab. This legislative win represents meaningful progress in expanding access for patients and adding a powerful new tool to our toolkit. This didn't happen by accident. It happened because this community was the one to show up. Whether you sent a letter, made a phone call, participated in Day on the Hill, shared patient stories, or engaged with your local legislative office, your advocacy truly made a difference. A special thank you goes to our partners at Heart Health Strategies, Dr. Todd Brown and the other members of our Government Affairs Committee, and of course our Smith-Buckland colleagues for their strategic leadership and their persistence. This success could not have been done without your dedication. But today, it's not just about celebrating this win, it's also about what comes next. We now have a 2-year window to implement, to refine, and demonstrate the impact of virtual and hybrid cardiopulmonary rehab. This is our moment to expand access, reach patients who are historically faced barriers to participation, and show that modern, flexible cardiac and pulmonary rehab delivery can be achieved. Policy progress only matters if it translates into patient impact in your programs. That's why we've brought together an exceptional panel of AACVPR leaders and national experts today. They're here to help you understand not just what the policy allows, but how to apply it in your own program, practically, thoughtfully, and sustainably. I encourage you to fully engage with the insights that they share with you and use this moment as a catalyst to begin developing your plan to implement this exciting tool in your program. Start small, but start today. And with that, I am honored to turn it over to our outstanding faculty. Thanks for being here today.
Thanks, Stacy, and welcome everybody to the webinar. My name is Todd Brown. I'm at UAB, where I'm the medical director of cardiac rehab, and then also have a number of roles with AACVPR, including our government affairs committee. What I want to do today is just talk a little bit as an overview about what has happened, and then I'll turn it over to some of the folks who actually have more experience physically delivering virtual services, and so they'll give you more than nuts and bolts. But I'll talk a little bit about what's happened and what we're allowed to do from a regulatory and statutory perspective. So first thing is, these are temporary changes, okay, in coverage for CR, ICR, and PR for patients who have Medicare. Okay, so it's temporary. It's only 2 years, but still, we want to take advantage of this. A couple of things. This does not apply to other respiratory services or set PAD. This only applies to cardiac rehab, intensive cardiac rehab, and pulmonary rehab services. It also does not apply to other insurances that are not Medicare. So it may not apply to a private payer or et cetera. Now, there are some pockets of coverage for non-Medicare patients, but for your non-Medicare patients, you'll need to check with each of those insurance companies about what their policies are. What we're talking about today is Medicare coverage for CR, ICR, and PR, okay? It's very important when we talk about delivery that we remember that these services are defined by statute. Okay, so nothing changes with that. You still do comprehensive CR, ICR, and PR. Okay, that means requirements for covered conditions, needing a referral from a physician, the requirements for supervision, ITPs, your session limits, what has to happen in a session, what your components are, that you need a medical director, et cetera, et cetera, et cetera, all still apply. Nothing changes. It's not a shorter session. It still has to be 31 plus minutes, et cetera, per session. Nothing changes as far as what you're delivering. All that's changing is how you deliver the services. And as a reminder, our services are delivered from two settings. One is the hospital outpatient department, which I'll call an HOPD. And then the second, less commonly, but still done through a physician's office. And the rules there are slightly different, but we'll cover kind of both locations. So a little bit on nomenclature to get us all on the same page. We talk about traditional in-center delivery. That means the patient comes to you. So you have a gym, and it's synchronous, meaning the patient and you interact in real time together. You're in person, you're together. That's sort of our traditional way that we deliver these services, okay? Virtual delivery, we define virtual delivery as synchronous real-time audio visual. That's what we're doing today. I'm on a camera. If I could see you, if you were on camera, we'd be seeing each other and we'd be communicating in real time. This is synchronous real-time audio-visual communication. We're not together in location, but we're together with each other through an audio-visual communication platform. It's very important that it has to include video. Okay, it has to be audio and visual, and it has to be real-time, where we communicate with each other in real time. Okay, so phone only or audio only or anything like that does not count. It has to be real-time audio-visual. Okay, for the duration of the sessions. If you're doing one session, and it has to be 31 plus minutes, you have to spend the 31 plus minutes on the session real time using audio visual communication. What we call remote delivery is asynchronous. That means you give the patient a prescription or a set of things to do, and then you check in with them later, okay? We may communicate at other times where we're not communicating with each other during the session, and we're not using audio visual communication potentially. That is not going to be covered, as we talk about later. What we're talking about being covered is virtual delivery. And then a hybrid delivery, don't make this more complicated than it needs to be. Just means you do more than one thing, okay? So you might have some in-person sessions, you might have some virtual sessions. Somebody comes 36 times and they come in the center 12 and they do 24 sessions virtually, that's hybrid, okay? Could be any combination of the two types of sessions, just a mixture of in-center and virtual delivery. Now, what are the wins from last year? Let's start with that, because this sort of sets the stage for where we're going to go this year. We had two huge wins last year. The first was we got virtual direct supervision permanent. Okay, so for a number of years now, supervising providers, a physician's assistant, nurse practitioner, or a clinical nurse specialist, or a physician could provide supervision of our services. Historically, that had to be done where they had to physically be able to go to your location. But for many years now, we've been able to do it on a temporary manner virtually. We can now do that permanently. CMS has decided to make this a permanent coverage or a permanent regulation to be able to do virtual direct supervision. That's for both in-person services. So if you have an off-campus facility and you have patients coming in person, you can have supervision from somebody who's not physically there as long as they can join a virtual platform, but also will obviously apply to services that are delivered virtually as well, okay? That again has to use real-time audio-visual communications technology. One thing to point out is, if I'm the supervising physician, I don't have to be on the session the whole time. I just need to be able to get paged and said, hey, we're having an issue with one of our patients. We need you to join our session, okay? Whether that be a session that's in person and I connect to the gym through an audio-visual communications platform, or a virtual session where the patient's at home and the cardiac or pulmonary rehab professional is in the gym or wherever they are, and I would join that kind of Zoom chat or whatever to be able to assess the patient. So I don't need to be there all the time. I just need to be available to join the session when needed. Okay, so you don't have to have somebody like a nurse practitioner on the thing the whole time, just when you need to have it done. That's now permanent, and that applies to both virtual sessions and in-person sessions. Okay. And then from the physician's office, cardiac ICR and PR codes are all now permanently on the Medicare telehealth services list. So this is a big win, and it allows physicians' offices to do virtual delivery through telehealth. So what happened this year? Okay, what happened was Congress passed the Consolidated Appropriations Act of 2026. And what this did was it reinstated virtual delivery of CR, ICR, and PR from hospital outpatient department-based programs to patients who are in their home at the time we deliver the services, okay? And it is in their home. It does not cover like going to the YMCA and doing the exercise there or at a neighbor's house or anything like that. Technically speaking, the patients are supposed to be in their home at the time those services are delivered, okay? It also extended some flexibilities for physician office-based programs. So remember I said those codes in the physician's office are permanently on the Medicare telehealth services list. The problem is there are rules about where the patient can be at the time the services are delivered. And traditionally, telehealth could not be delivered in the home. It also had to be like in rural communities, et cetera. Those conditions have been waived for 2 years. So now it can be in the home and there's no geographic restriction. Patients can be in an urban environment, et cetera, to receive these services from a physician's office. So for both the hospital outpatient department and the physician office setting, this act has given us temporary approval to do in-home services for 2 years, okay? And that's really important. But remember, it has to be virtual. It has to be real-time audio-visual communications technology for both hospital-based programs and physician office-based programs. Audio-only or asynchronous services are not covered. And this extends to the end of next year, December 31st, 2027, okay? We are absolutely going to be advocating for that to be positioned longer than that. But for now, it's a big win to get 2 years of coverage. So what does this mean? As I said, we have a 2-year opportunity, okay? But it doesn't mean you have to do everything virtual, okay? It just means that we have the option to do this, okay? We all know that the in-center service is tried and true. We have a lot of years of experience doing in-center delivery. And for many patients, that's the best way to do this. But it's not the best way to do this for all patients. Some patients may need a couple of sessions and then can be turned virtually. Some may want to do everything virtually. It really just gives us an opportunity to have a better way to reach our patients and to truly create an individualized treatment plan where you can individualize how you deliver services to your patients, whether they are in-center or virtual sessions or some combination thereof, so that you can meet your patients where they are and better help your patients. And hopefully we can close the gap on the 80% of people that never attend our services. It really gives us a chance to widen the net and get more people in and really take care of patients in a way that allows them to benefit from our services, okay? You now have the flexibility to develop hybrid programs, okay? And very importantly, Congress and CMS is going to count, okay? They're going to count whether we do this or not. If we go to them in 2 years and say, we want you to extend these services beyond 2027, and they say, well, guys, y'all don't do this. We looked at our billing data and nobody's doing virtual delivery. They're going to lose interest in this. They're not going to continue to allow us to do this. So this gives us an opportunity, and I would submit to you an obligation to actually do this if we really want to make this permanent and we really want to make this part of the future of the services that we deliver. So now is the time. We need to do this. I'd point you to this document, which is a consensus statement that we published last year in JCRP. I think a number of the speakers that come after me are going to talk about some of the information in this, but this really does give you some additional information on ACPPR's position on this and how you should deliver these services. And I'll turn it over to the next steps, which is there's a few things we don't know about just yet. Okay, so we are awaiting guidance from CMS about things like modifiers. So we assume that when you do a virtual session, they're going to want a modifier attached to that. If you remember, during the public health emergency from COVID, we had to actually submit addresses for patients' homes to kind of register their home as part of the hospital. We are really hoping we don't have to do that, but we're still waiting on some advice about exactly how this is going to go. Stay tuned to your email address and your use so that as we send out ACPR regulatory updates, as soon as we have information on this in terms of how exactly you bill for this, we will let you know. I'm pretty sure the codes are going to be the same. So, for cardiac rehab, for instance, you'll bill a 93797 code. The question is, do you have to put a modifier and do you have to have an address registered? Okay. We will continue, as I mentioned earlier, to advocate for the Sustainable Cardiopulmonary Rehabilitation in the Home Act. Okay, this is the permanent coverage. So the language from this act was incorporated into the bill that passed in January, but only for 2 years. We continue to advocate for this on a permanent nature, and we'll be on the Hill on March 4th, and I hope all of you come join me on the Hill on March 4th. We'll continue to be advocating for this when we go to the Hill next month, okay? And we will also continue to advocate for permanent extension of flexibilities for telehealth delivered services in physicians' offices, okay? So we will continue to push for this. Our advocacy is not over. We have a short-term win, but we have a long-term war to fight, and we'll continue to fight for that. And I'll now turn it over to Stephen and the rest of the group, who will get into more about how you do it. My job was to talk a little bit about the coverage. So thank you for joining, and I'll turn it over to Stephen.
Thanks, Dr. Brown. Over the next 10 minutes, I want to speak a little bit towards the evidence that we can look at that supports the use of a hybrid model or a virtual model for cardiac and pulmonary rehabilitation, and how do we go about measuring our outcomes if the patient's not always coming into the session. So these are the topics that I want to address next. So you've all seen this before. This came out of a document that Dr. Brown helped lead, and it refers to the core components of cardiac rehabilitation. And on the left there are the outcome measures that many of us measure in our rehabilitation programs now. And on the right are some of the actual measurements we might take to assess those outcomes and some thresholds associated with those. I'm not going to go line by line, but these are pretty well familiar to us. This is the same concept, but now it applies to pulmonary rehabilitation. Again, we have items on the left that refer to core components for pulmonary rehabilitation. And drawing from those, on the right there, we have a table with 3 identified key outcome measures: functional capacity, dyspnea, and health-related quality of life. And for each of those, there's no thresholds given here, but for each of those, a measurement we might do to, or more, that we might do to address the outcome. So this is information we know, and we'll take that as a given. So the question becomes, if we have items we want to measure, how are we going to measure this if the patients don't come in at all, if they go purely virtual, or come in very rarely to our rehab center? How do we connect with them to get the data we want? The most immediate way is, the first off is, we're smart people. Let's figure this out. Be creative, and whenever feasible, take advantage of the fact that the patients may occasionally come in for an in-facility visit. Even though they might be in the hybrid model, they may come in, or you can ask them to come in for an in-facility visit. And then at that time, you can gather a lot of the information you want to have. But most important, be creative. And that's what I want to touch base on now, in some of the ways we might be able to do this. So let's look at measuring things that might be collected by questionnaire: health-related quality of life, physical activity status, nutrition, psychosocial questions, etc. Easily, you can email documents to people and have them fill it out by hand and then have them mail it back to you. That's the most direct. In rare cases, if there's reading difficulties or terminology difficulties or technology difficulties, then maybe you do interview them over the phone. This might be the least reliable, least valid, but you could interview them over the phone. Again, as I mentioned before, in-person visits would work very, very well. If you know they're coming in for a in-facility visit as part of their hybrid plan, then capture the questionnaires before they start, preferably before they start their exercise that day. And then work with your IT folks to see how you can send through the patient portals that exist. In Epic, the patient portal is MyChart, and mail directly to them PDFs, or send them directly through MyChart PDFs that they can complete and then return back to you. You may have to restructure those or retype those, so to speak, within the format they want from IT, but it's one way to get the information exchanged as well. Well, a little bit more difficult would be measuring a change in exercise capacity, right? 6 minute walk distance, exercise time, change in MET level, peak VO2. These are things that, you have to have a face-to-face, usually a face-to-face contact with somebody to get these measured. So in this case, if it is something that's, directly collected data, then the patient's going to have to come in. It's not unreasonable to ask them, hey, at baseline and when the program's over, we're going to need you to come in to to collect some 6 minute walk data from you. It's a reasonable expectation to ask people to come in to visits. If they say they can't come in, then you would probably lose this data if you want to measure 6 minute walk or peak VO2. You can also collect data relative to change in METs based on the workloads that they're doing at home. Now, they'll have to have a piece of equipment that can give you watts or speed or grade or kiloponds or some unit of measure that you can use to convert to METs. So if they're training at 2 METs during the first week of rehab and at the last week of rehab, they're now training at 5 METs. They've had a change in METs of 3 METs, and we want to be able to quantify that. So getting information off their equipment, again, speed and grade and whatnot, would be an easy way to do it, that you could do that virtually. You don't necessarily have to have them come in for that information. They can just report that to you. And there are some technology-based platforms out there like GPS-guided 6 minute walk collection that we don't have good experience on. We haven't really applied in the rehab setting, so I'd be a little bit reluctant to use those. And there's also some prediction models that are out there to look at 6 minute walk based upon other data collected, and I might shy away from those, but I've given you a couple good examples that would work. Then there's collection of biomarkers, blood pressure, lipids, A1C. Again, some of this stuff some of this information you can grab and measure it in person when they come into rehab, before or after a visit, before the start of rehab in general, or at the end. But also some of it can be self-reported, body weight. I think that'd be acceptable. You can glean from the medical record recent lipid values, A1C values, blood pressure values. Those all work. And there are some remote capabilities for some of this information. Blood pressure for sure, heart rate for sure can be transmitted, and by a technology-based platform, or again have them come in for a hybrid session. All right, let's shift now a little bit to what's the evidence if you compare hybrid versus facility only, or virtual versus facility only. And by virtual, I'm talking about a synchronized AV connection, which would be part of a hybrid model if you're using the hybrid model. What's our evidence that talks about some of these key outcomes that we would be looking at? So let's first look at clinical outcomes, hospitalization and mortality. For cardiac rehabilitation, there is good preliminary information that suggests that it too will favorably work on all-cause hospitalization and all-cause mortality. It's not robust, it's preliminary, but and further work's needed to demonstrate that. With respect to exercise capacity, change in VO2, change in 6 minute walk distance, very good data there that shows moderate improvements with cardiac rehabilitation using the hybrid model, especially as compared to a traditional model. Quality of life, we also have that through the hybrid model. Again, favorable effect. Attendance seems to be equivalent, the data that's out there right now, or possibly even a little bit better with the virtual hybrid model. At minimum, though, it's equivalent. And we don't have much data on dyspnea, which will be a pulmonary application. Sticking with cardiac for just a second, many of you have seen this data that we've presented before. This is data from our IA-10 trial, and I just want to move through it quickly. The first grouping here in the terms of the top rows, we compared number of sessions completed and the percentage of people completing 36 visits. And we're comparing here straight up facility versus hybrid including virtual. And you can see there was no difference between the two groups. whether they used one model or the other. In this next slide now for exercise capacity, same thing again, measured peak oxygen uptake or 6-minute walk distance or just exercise time. 3 measures of exercise capacity, no P levels, no difference between the two groups. VO2 up about 2 mLs, exercise time up about 2 minutes, 1.5 to 2 minutes, 6-minute walk distance equally improved about 45 to 50 meters. And then again, same thing for quality of life using the Dartmouth Coop score. Lower is better. And both groups decreased, no difference between the groups, facility versus hybrid, by about 3.5 to 4 total score points. Let's look at the same thing now for pulmonary rehabilitation. And as you'll see here, there's just much less data. Hint, hint, hint to the group that I'm speaking to. This would be areas that you can really help contribute. There's much less data that looks at the effectiveness of hybrid pulmonary rehabilitation. There's just so few centers that are doing this. But if you're thinking about it, please collect good data. We're happy to help you with this. If you have questions, data is needed. But what some data we do have is for exercise capacity, seems to be similar with respect to 6-minute walk improvement distances, distances in 6-minute walk. And that data does exist. We don't have any quality of life data now that directly compares hybrid or virtual pulmonary rehab to in facility. Attendance seems to be equivalent, like cardiac rehab was, seems to be equivalent whether the patients go hybrid or in person. Dyspnea seems to be favorably improved, and as I mentioned, much more data is desperately needed in the U.S. Oh, did I skip a slide? I guess I skipped a slide. Okay. All right, so it gives me great pleasure to introduce Carrie Ann Dual, and she's going to cover some of the patient selection issues.
Thank you, Stephen. Can you advance the slide? Thank you. So we're going to jump into patient selection. And the first things I wanted to mention to you is you're already experts in triaging referrals and making sure that your patients are eligible. We're just throwing kind of another little wrench into the system is now we have to think about the mode of delivery. So first, you need to think about what options will be available for our facility. Will we have in-person and virtual? Will we also have that hybrid model that's been defined already? Then we should develop some kind of patient selection criteria. Now, we already know what patients are eligible for cardiac and pulmonary rehab, but we might want to consider what are some things of why one mode might be a little bit more appropriate for a group of patients versus another. And that will be on my next slide where we'll kind of talk through that. And you might need to think about updating your current ordering processes. Do you need to update some of the language? In that, do you need to be making sure that you are updating your referring providers and marketing materials? Making sure that those providers referring to cardiac and pulmonary rehab are aware of your new options because maybe they didn't make that referral because a patient simply was not able to attend in person. And don't forget to collaborate with all those ordering providers and other services as needed as you're setting up your virtual. And one tip I could give you, and this has kind of already been mentioned with Stephen's presentation, is that in-person evaluation could really be key to helping with this patient selection process. We all know as clinicians that a patient can look one way on paper, but when you see them in person and you do some of those intake eval things that you might think of another way. And last I want to say on this slide is just because you select one mode to start off with, maybe you select in-person only, it doesn't mean that that person eventually might not be appropriate for a hybrid. So it's okay, it might change. Next slide. So on the right of this slide, I want to mention this comes from the consensus statement. This is a table of not necessarily people that you would not allow in a virtual, but considerations that you might want to discuss really refer back to. And so you're always going to be using that risk stratification process. You're going to be looking at their medical history. Does this patient need continuous telemetry, oximetry monitoring? If that is the case of yes, then that is going to make your answer of yes, we're probably going to be doing an in-person program for that particular patient. What is this patient's fall risk? What about attendance or motivation? And that could go either way. Would in-person or would a virtual or hybrid program be more appropriate for that particular patient? Mental health, cognitive status, maybe an in-person group appointments, especially for someone who has like PTSD, that might not be the best fit for them. And something I think when we bring this up is a lot of times patients say, well, gosh, our higher risk populations, that there's no way, Karen, that they can do virtual. But yes, they can. There's the HF Action trial out there. There's a number of publications that have shown like this is safe for patients, for example, with heart failure. And a tip would be to you all as you're getting started with virtual is it's okay to start slow and just not open the gates right away. And I would always what I train all of our providers in is start with a patient that you feel most comfortable with. So if it's a post-PCI patient, if it's a pretty stable COPD patient to start off with, that's okay to start there, get your feet wet, get this whole virtual thing figured out, and then open it up from there. Next slide. So there are, in addition to all the medical aspects of things, and just for time's sake, I wasn't able to go through all that table. That could be a whole hour discussion in itself, but there are patient and healthcare system determinants that might definitely impact, is a patient going to go to virtual or will they be most appropriate for in-person? So really you might have to take into consideration things that you haven't really thought about before, those financial barriers, transportation, employment or caregiver options. For virtual patients, sometimes if they're currently employed or they are a caregiver, having an additional option of not traveling is just a great for them. Technology availability or their literacy. Now, for some geographic locations, you might say technology is no issue. Our patients have that. But there has been experiences where they might not have that technology and they might, in person is definitely more appropriate. Communication barriers, psychosocial status, and not enough is said about patient preference. If they meet the needs for both types of programs or all three programs that you're offering, what is their preference? What do they feel like is going to meet their needs and most sustainable in all these health, behavior changes that they're doing? Where is their motivation going to be? And on the other side, these healthcare system determinants. So your availability, your wait list, what's that geographic location, what is available in that area? And then will your healthcare system be providing technology assistance to your patients as they try to figure out doing virtual appointments? And so the next thing I'll be talking about is more about safety and emergency. So once you have that patient into the program, let's talk about some of those safety steps that need to be put in place. So we've already mentioned that there's a medical director, virtual supervision, and the supervision of your providers helping with your cardiac and pulmonary rehab program. So obviously that is going to be staying in place when you're having these virtual programs. You already have these really great existing policies and protocols at your facility for your in-person cardiac and pulmonary rehab. So we're not recreating the wheel. We're just maybe tweaking those a little bit, editing them where they need to. In those, you have those strategies of how do we prevent adverse events? How do we manage if an adverse event happens? And then how are we tracking and documenting at our medical facility if an event would happen? So those are likely already in place. The piece is how do we deal with that and then that virtual aspect of things. And what the great news is we're not the first program to be doing telehealth. We have mental health providers. We have other people in our healthcare systems who've been doing more telehealth. So connect with your telehealth departments, connect with those other groups, information technology, patient safety, to making sure that we're able to update those existing policies as needed. On the staff side, some facilities I've heard of having mandated trainings or additional things to work within the virtual platform. And even if you don't, I would encourage you to have those drills. Just as we have mock scenarios and drills and competency checkoffs in our in-person programs, do that in the virtual side too. make sure that your clinicians feel comfortable in the virtual platform and how to deal with something if it's happening. That intake assessment is key. You might be needing to add some things where we usually talk about home life, but we're really going to be having to focus on home safety concerns. Who's their support system? Will they have people there with them during their virtual appointments? Assistive devices that are needed. So that's another safety checkpoint as well. And it's already been mentioned, but don't forget about your individual treatment plans. A great opportunity. You're being creative. You're having that individualized treatment plan. That's going to ensure that progress and safety throughout their cardiac and pulmonary rehab. So what if something does happen? Well, we all know that you have those steps already in place in your in-person program. So you might have to modify exercise prescription. So how might that look like in a virtual session? You might have to stop exercise. You might have to call in that medical director, that supervisory provider. So in that situation, when I know someone else is going to talk about virtual platforms, consider if this is a group situation. Are we having a breakout room? Will we have additional support staff? Will we be just ending the call? How will we deal with that particular patient at that time? And then are we continuing rehab for the rest of the group or not? So those are things to really start thinking about, figuring out your technology and considering what would we do in this situation. Now, it's really rare that you might have to call EMS, but let's have a plan in place. So that could be that there's suicide ideation. That could be because they're having some medical emergency. Something that I would encourage you, it's not on this slide, but at the very beginning of the appointment, we encourage our patients, at least I do, to have their front door unlocked. Let's prevent one extra barrier that if I'd have to call 911 or initiate that response, that there's not that barrier of getting through the front door to help that patient. At the beginning, you should make sure there's verbal consent for every appointment, know who's going to be joining those appointments or if there's others with them, their physical location, which Dr. Brown talked about, having that in the home, but just confirm their address, their contact information if for some reason their virtual aspect is lost, and their emergency contacts. Next slide. And for home exercise plans, so outside of these virtual aspects, we're already teaching all of our patients the importance of exercising at home when we have them in our in-person programs. But don't forget that really key of making sure that these patients understand their exercise prescription. They know how to recognize change in symptoms, how to monitor those vitals, when to stop exercising. Don't forget to teach them about the talk test, the RPE scales, those aspects that can really come into key with their home exercise program. But then even more now, when do I call 911? When do I initiate that? And when do I not call me? I always tell my patients, don't call me when there's an emergency. That's when you need to initiate EMS. But as part of that cardiac and pulmonary rehab provider, I do want to be updated because that's going to take a part of your course of care moving forward. Next slide. So with that, I thank you for having the opportunity to come and talk about those factors, and I'm going to pass the baton to Robert Berry.
Thanks, Carrie, and all my other faculty members. I really appreciate it. You've actually made my job really easy. I'm going to be talking about the technical requirements for virtual cardiac and pulmonary rehabilitation and some considerations, things to think about. So, Okay. So as Dr. Brown mentioned, that the only way this is covered through CMS is you have to have live two-way audio-visual communication. So some kind of web-based conferencing platform. Your hospital has been doing telehealth services now for several years post-pandemic. So there should be something available. So the technical requirements from the provider side are actually not that extensive. You're going to need a webcam. You're going to need a microphone. You're going to need some kind of platform that's going to let you interact with patients. we recommend that you use a headset. It reduces the ambient noise. It makes it a whole lot easier to stay focused on what you're doing. One thing that I'm really sort of hoping that the attendees to this webinar get is a sense that this is really not that hard to do. You can start this up relatively easily and relatively cheaply. And that it's the same cardiac and pulmonary rehab you've always done. It's just being delivered through a different media. And that's the big difference. Other than that, you all know how to do this very, very, very well. So for the provider side, just a webcam, microphone, possibly a headset. For patients, I can't tell you how I know this, but you have to make sure the patient has an internet-capable device. They can run whatever conferencing platform you're using. It could be a tablet, it could be a smartphone. It's probably not going to be a flip phone. Okay. We recommend that they have a stable internet connection. Wi-Fi is preferred. You can use cellular data. The picture might be a little bit jumpy. The quality might be a little bit off. They don't really use a lot of cellular data doing the video visits. And same as for the provider, we would recommend that they have earbuds or a headset. It reduces the ambient noise. If they would be exercising in a space that's open to other people, then if they're using earbuds, nobody can hear what the provider is saying. And you just have to kind of make sure that the patient is sort of, covering their bases in terms of what they're divulging about themselves, which kind of leads us into the next point here. So considerations for a homegrown program, you absolutely positively have to maintain HIPAA compliance. That means you're not going to be able to use like FaceTime or some other product like that. It needs to be something that's secure and isn't going to get divulge anything. Talk to the patients about making sure that they don't say anything about themselves that they wouldn't want other people to know about. And I'm assuming that you're doing a group session. So you can't really commit a HIPAA violation on yourself. But if you don't want people to know that you had a heart attack, then don't say that you had a heart attack. When you're logging into the systems, you want to maintain confidentiality. So I would encourage people to use maybe their first name and last initial or a nickname or something, just to keep things private. Work with your hospital's telehealth and IT departments. Find out what's out there already. At this point in time, those systems are pretty well established. So leverage the knowledge that's already out there in your health system on how to do this. This point about vetting patients before admitting to a session, what I mean by that is you want to make sure they belong there. So we only have one link for each one of our classes. So if we had 4 classes, we'd have 4 separate and distinct links. They never expire. That's what we send to the patients through the patient portal so they can log into these sessions. And you want to make sure that somewhere down the road, somebody doesn't want to jump into a session and check on how their cardiac and pulmonary rehab buddies are doing. If you have a way of putting them in a waiting room and making sure they're on the schedule, that helps guard against that. Optimize visuals for mobile devices. Early on, we were using a narrated PowerPoint presentation to do our education. And it just turns out that on a screen the size of a smartphone, it's really hard to read. So that's something that we learned. So optimize any education you're doing, make sure that it's legible on a mobile device. If you're doing a hybrid program, consider making sure that the class times and the education schedule are similar. Okay, same. So if they're hybrid, they're in the 7:30 a.m. Facility-based class, or also in the 7:30 a.m. Virtual class. That's one less thing for patients to remember. And the education, if they're going back and forth between hybrid and virtual, you want to make sure they're not missing educational sessions and they're not being given sessions repeatedly. You keep getting the same thing. It's kind of a big patient dissatisfier. If you were going to go with a vendor, okay, everything I just said about homegrown program consideration still applies. The additional considerations are referrals. Are you going to be sending these to the vendors, or is the vendor going to have access to your EMR and they're going to look for them themselves? Are the sessions going to be hybrid, or are they going to be fully virtual? Who's going to do what? Billing, is the vendor providing the service, but the hospital is billing for it, or is the vendor billing on their own? How does the revenue get split up? Is it a straight percentage? Is it based on volume? What are the qualifications of the staff? Okay. Again, we've all been doing cardiac and pulmonary rehab for a very long time, and generally speaking, we do it very, very well. We want to make sure that our patients have access to the same quality of care as in our center-based programs. Make sure that the vendors are delivering all of the other core components, psychosocial, nutritional, okay, all the stuff that you have to have in regular cardiac rehab. By statute, Dr. Brown went over this. By statute, those things have to be included in virtual rehab. And lastly, considerations for vendors, does the program meet your standards for cardiac and pulmonary rehab? Because patients may not realize that you've transferred their care to a third party, and they think that they're getting hospital services from the community hospital, or they're getting. So make sure it meets your standards, because that's what they're going to be talking about when they're out in the community. So moving on to exercise prescription and progression in a virtual environment. Remember that all of the benefits associated with cardiac and pulmonary rehab are primarily tied to changes in skeletal muscle, the physiology of the muscle, the oxidative enzymes in the mitochondria. Okay. So it stands to reason, if we want to have similar benefits, we have to train at similar intensity as a traditional cardiac and pulmonary rehab if we want to get the same results. Try to resist the urge to lowball and decrease intensity during virtual sessions just because the patient's not right in front of you. Okay, that's not going to have the best outcomes. There's lots of different ways you can monitor exercise intensity. You can use heart rate if you have a target heart rate range from a stress test. You can use RPE. I really like the talk test. You're talking to the patients and you can hear them, you can hear their breathing, and you can kind of tell when they're getting to that point where they're starting to struggle a little bit. Or conversely, you can tell when they're really not pushing themselves very hard at all, and they should probably pick it up a little bit. When I say introduce virtual cardiac and pulmonary rehab based on patient presentation, like others have said before me on this webinar, this is not a one-size-fits-all solution. So, when you're interacting with the patient before they're even in their program, you have to kind of use your sixth sense as a clinician as to what their comfort level is on doing this virtually. It's not unreasonable that a lot of people are really anxious about initiating physical activity after a cardiac event or a pulmonary event. So maybe you start off and say, you know what, we're going to do several sessions in the facility-based, and if you're progressing the way we think we're going to progress, what do you think about maybe doing one session a week next week, one session virtual next week, and then maybe pick it up that way? And on the other hand, you're going to have people that are super, super gung-ho, and like they just want to go all virtual. I've got a guy right now that's happening with. He owns his own business. He works 24/7, and I don't think I'm exaggerating at all there. And the time he's going to and from the facility-based rehab he's not making money, and he needs to. So kind of get a feel for where these folks are. Progression, meet the people where they are initially. Again, if you're using RPE, maybe you're pushing for an RPE of 11 to 12 on the 6 to 20 Borg scale. And initially, if you have more deconditioned patients, maybe you focus on increasing duration before you increase intensity. The goal is always to get to 150 minutes of moderate intensity exercise every week. And that's a minimum. Okay, we're going to get more benefits from more exercise. We all know that. As the patient starts to demonstrate improvement, start thinking about pushing them up to the top of the range of whatever measure you're using for intensity. So if it's RPE, start pushing them up to like the 13, 14, maybe even the 15 on the 6 to 20 scale. If it's target heart rate range and you started off at 50% of heart rate reserve, start thinking about pushing them up to 70 or 80%. The more they put into the exercise, just like facility-based, the more they're going to get out of it. As a talk test, you can actually, on select individuals, you could go and do intervals where the talk test is equivocal. They're having a little bit of trouble getting, they can talk, they're having a little bit of trouble singing, maybe even like the sentences have to be fairly short. But again, the exercise prescription, it's an art and a science. So you meet the patients where they are, have clear-cut goals in your mind where you want to go, and then you move forward based on how they're responding to what you're doing. The AACVPR consensus statement on virtual cardiac and pulmonary rehab has some excellent information on progressing patients, and I would definitely encourage you to look at that. And I am going to turn this over to my friend and colleague, Dr. Hughes.
Thank you, Robert. And so I'm here to talk about patient education and psychosocial management in the limited time that we have remaining, but I promise we will end on time. I also believe that the slides will be available, and so have no fear. That should be available to you. Let's start with the good news. Do the non-exercise components of cardiac rehab improve outcomes? The answer is yes. And so it turns out that if it's a comprehensively delivered cardiac rehabilitation program, each of the individual components is actually contributing, and collectively they're all contributing to good outcomes. And it's absolutely true that the exercise component is foundational, absolutely. But in the systematic review and meta-analysis, what you find is that psychosocial management and patient education are also contributing to reduced risk of mortality and other adverse events across a variety of things. Now, and again, there's less data for pulmonary rehabilitation, but we have every reason to believe that there's a reason to have the core components implemented in hybrid and virtual and remote cardiac and pulmonary rehabilitation. So let's talk about patient education. And here I'm going to only be able to comment on a very high level view of what's going on, but I just want to make some observations. I see this as an opportunity to reconceptualize what we're doing with patient education in pulmonary and cardiac rehabilitation when we consider moving that to a hybrid and a virtual space. So here are the core components of cardiac rehabilitation. There are the core components of pulmonary rehabilitation. The thing I want to point out is that patient education is not a core component. Rather, it's part of every intervention. Here is a figure from, I forgot to put the citation, but the citation's coming up in about 3 slides. Every intervention in cardiac and pulmonary rehabilitation involves patient education. From the exercise training to the psychosocial assessment, they all have patient education involved. And so here's how I think we could be thinking about this as we are creative and entrepreneurial in figuring out how to deliver quality patient education in hybrid pulmonary and cardiac rehabilitation. Most of us are going to be thinking about the methods. Like, shall I have videos that I play? Shall we have a discussion? Shall I email or hand people written materials? There are many different methods of doing patient education, and then there are several modes of patient education. And these include in-person, synchronous video telecommunications, and asynchronous education, which could be text messages. It could be a patient portal. It could be a YouTube channel. It could be a learning management system. Any kind of mode is possible. But let's think beyond methods and modes, and let's think about goals. And so here's my metaphor for you. Every mature healthcare profession now operates using competency-based education. And I think we can conceptualize patient education in the same way. There are knowledge competencies, which is to say there are things that you want your patients to know. There are skill competencies, which is to say things that you would like your patients to be able to do. You would like them to be able to use the exercise equipment correctly. You would like them to be able to use the inhaler correctly. You would like them to know how often they're supposed to take each medication. You know, there's knowledge and there's skill. One thing I would add is some competency frameworks also have like values or attitude competencies, and this requires persuasion. This is what leads to behavior change. And so my suggestion as we move forward with, you know, should it be written? Should it be a discussion? Should it be a one-on-one interaction? How should we do these things? Let's go back to what are the goals of patient education? Because as we all know, having the information passively wash over you or being handed a packet of information upon discharge from the hospital, that is not education any more than if someone sits in a seat for 45 hours in a semester and receives 3 credits. That is not education. It's, can you show me that you know the things you're supposed to know? We have to define what those are. That you can do the things we need you to be able to do. We have to define what those are. And that you're changing your behavior in the direction that we want, that we have persuaded you to do some of the things we need you to do. And I don't have time to get into it, but each of those aligns perfectly with a way of educating people. And just as an example, if you want to show someone the skill of using exercise equipment correctly, the best way is to explicitly and directly instruct them and then to provide feedback. You know, no, not that way, this way. And we could go on and on about that. But let's move on to psychosocial management. And here, again, I'm only going to have time to make a couple brief comments. So let's see. This is the one that I should have had for the citation on the other one. And the thing I want to point out about this scientific statement from AACVPR, the American Heart Association, and the American College of Cardiology is that cardiac rehabilitation and pulmonary rehabilitation are evidence-based interventions that always include patient education, health behavior modification, and exercise training. And yet, so here are the target behaviors. You'll see stress management there. Okay, what I realized as I was reviewing this is that psychosocial management is not the same. It's not identical to stress management. And I think that's an important concept to keep in mind because there are some parts of psychosocial management that are built into our workflow and are not very hard. And then there are other parts that are more difficult. And psychosocial management is broader than stress management. My preference would be that all programs have a stress management component that is an intervention delivered as part of the hybrid or in-person or virtual cardiac and pulmonary rehabilitation. However, psychosocial management is broader, and that's where things start to get really hard. And so in that scientific statement, it was not always clear when they were reviewing programs for home-based cardiac rehabilitation and center-based rehabilitation exactly what people were doing. And I think this is true. This is true. This is our fear as there are more and more providers of center and hybrid and virtual and remote cardiac and pulmonary rehabilitation. Are they doing all of the core components? And sometimes in the literature, it doesn't even say. And so I suggest that we go right from the core component statement and we just follow the plan of evaluation, intervention, goals, and outcomes. The evaluation, goals, and outcomes are baked into the individual treatment plan. So that's the easy part. And then the hard part is determining what you can do for the intervention. And so we're going to rely on the ITP, and you can use the program certification application for guidance because as one of the required elements of pulmonary rehabilitation, you will see psychosocial listed right there. And then some of the steps are assessment and reassessment, and that hits your initial patient assessment and whether or not they're progressing towards goals. The difficult part is in the middle there with what interventions can we provide. And it's effectively the same for cardiac rehabilitation. We're going to rely on our ITP to execute psychosocial management. And so here, the hard part is that there is stress management that we can all provide briefly. However, people have far more needs than that. And that's going to be something that we're going to have to continue the conversation with because I'm already out of time today. So my main point, though, is that this is just the beginning of the conversation. And one way of conceptualizing this is that we can do stress management as an intervention that's baked in, and then psychosocial management is a broader concept that starts with the assessment and the discharge repeat assessment. And with that, I'm going to hand it over to our next speaker.
Thanks, Joel. Thank you guys so much. What an incredible depth of knowledge and perspective that we've heard from these great leaders in the field. Thank you for sharing your expertise and your experiences. What an exciting time for our community. I encourage you to take today's inspiration forward as you consider how to integrate this new tool into your programs. AACVPR is committed to supporting you in every way. Along the steps that you're taking through continued education, shared resources, and peer connection. So stay connected with us as you work towards offering hybrid cardiopulmonary rehab as part of your services. Thank you for your dedication to your patients, your programs, and your profession. The future of cardiac and pulmonary rehab is really stronger because of all of you. Thanks so much.